Welcome everybody to our webinar today about nitrous oxide. What is up with Whippets, which in case you've never heard that word before, it's sort of a slang term for nitrous oxide. I am Alicia Gonzalez. I am the Director of Clinical Training here at the Bridge program, and I'm so excited to have some experts join me today to talk about this topic. But in case you are new to us, we at Bridge are a program of the Public Health Institute. We are publicly funded by the California Department of Healthcare Services and by DHCS in the work that we do. And so in that vein, we don't have any private funding. We do not have any financial disclosures. None of our speakers today are paid by pharma or anything like that. But if we do slip and say brand names, please be aware it's not on purpose. It's just the words that we're most used to saying. For example, if we say Narcan instead of naloxone, it's just a word that we're used to saying and that our patients use, but there is no financial disclosure to announce. I mentioned as well, in case you are new to us, I want to make sure that you are familiar with what we do at Bridge. And our main goal at Bridge is to make treatment for any substance use disorder easy to access for patients anywhere that they need it throughout our state in California, but also across the nation. The way we do that is number one, making access to medication-based treatment easy and accessible at every single emergency department, and ideally at some point, any clinician that you could encounter, period, whether it's in the primary care clinic, OBGYN, anybody. But we also want to respect that the acute care setting is for acute care. And so we want to connect our patients with a warm handoff and a smooth process into ongoing care in the community, whether it's primary care, addiction care, other social support services, et cetera. And then finally, promoting a culture of harm reduction, which is in part getting rid of that stigma and a lot of the nonsense that's been in the way of us being compassionate humans in this work for a long time, but also talking to our patients about actually mitigating the harms of their substance use. And that is going to be one of the things that we talk about today, which I mentioned. We are going to dive into talking about nitrous oxide. And what's so fun about this is that in January, we every year do this big look ahead webinar where we talk about what's hot, what's happening. And one of the items that we mentioned was nitrous, because we are getting so many questions about nitrous from all of you. So we wanted to do just the rest of this half an hour deep dive into that topic and that topic alone. And I am so excited, genuinely, to have these two guests with me today to share their wisdom. And some of it is lessons learned from personal experience about nitrous oxide. So let's have my guests introduce themselves and give us a brief summary of who you are and what is the work that you do. We'll start with you, Robert. First time here with us at Bridge. Let us know who you are.
Hello, everyone. Thanks for having me to Bridge. My name's Robert. I'm board certified in emergency medicine, and I just, as of last week, finished my fellowship in toxicology at UC Davis, where I was lucky enough to also work very closely with our addiction medicine fellows and substance use intervention team at UC Davis. And I'll be sticking around the Sacramento area.
Wonderful. So good to have you. We love bringing new faces onto our webinars. I keep wanting to say podcasts. Anyway, Kai, what about you?
Yeah, hi, I'm Kai. I work currently as a project manager with Bridge. I'm also an MPH candidate and a fellow at Johns Hopkins this year. And before Bridge, I worked with community-based harm reduction organizations here in Oakland. But really, I'm passionate about this work due to my 2+ decades of lived and living experience with drug use, which for me includes total abstinence from opioids and kind of a more like harm reductionist, moderated use of both prescribed and non-prescribed drugs to manage my mental health and to honestly just kind of increase my enjoyment of my one precious life.
I always love having you here as a person to bring just like a major dose of reality, I think, which is really nice. Sometimes we feel like we're only bringing in the medical perspective. And so I really always appreciate your vulnerability and being willing to be here with us. So I want to do a little bit of level setting very quickly, because for any of our clinical people on this webinar or watching it later, you've probably heard of nitrous oxide, or you're familiar with it as an actual medication that we use in medicine, in the emergency department, some dentists, procedural dentists, et cetera. And that's because nitrous is actually a very, very good sedating agent. It's actually very safe compared to a lot of medications that we use. And so we have used it in the medical community for a really long time. And it's starting to gain popularity again as we search for non-opioid medications that we can use for things like during pain control during procedures. There was a time period where it was very popular in hospitals and it had to be gotten rid of, in part because staff were sort of notoriously abusing the nitrous. But hospitals have gotten a lot smarter. Things have changed. There's much more, regulation and monitoring, et cetera, locking the cage, et cetera, of where you keep your nitrous. And so, again, because we are really trying to find good, safe options for patients in the hospital setting, we want to support that nitrous is a really important medicine. And we love that we're seeing more hospitals bring that back as an option. Nudge, nudge to any of my hospitals. I would love to have this medicine. So I don't want to knock nitrous altogether. It's a really important tool in our toolbox doing emergency care. But in this context, when we're talking about nitrous as a recreational drug or a drug of abuse, we're really talking about what a lot of people will call whippets. And so I want to really make sure that in this context, we understand the basics here, especially because over the last 6 months or so, like I mentioned, we're getting so many questions from a lot of our navigators about seeing a spike in nitrous use. Again, it's kind of coming back in vogue. So I wanted to talk today about what is it to even like use nitrous, what can happen, what are the negative effects, how can you help people who are using nitrous, and what does harm reduction look like? So those are kind of the big buckets that we're going to cover today. So Kai, I'm going to call on you first if that's okay. I would love to hear, can you just explain for me from a regular non-doctor perspective, in your mind, when you think nitrous oxide, what is that? Like, what happens when you take it? Why is it popular? Bring me up to speed on what this is for the
Absolutely.
average person.
Yeah, what a fun flashback to my early 20s and kind of like reliving my later teens, early 20s thinking about this subject. So when we would purchase Whippets, we would purchase these like little tiny silver canisters, which can then be like cracked open and either released into a balloon or into a whipped cream dispenser or kind of whatever you have on hand and inhaled. And that causes a very dissociative feeling where it's like a euphoric happiness, but also like, kind of like laughter is something that a lot of people experience, which is how it ended up with that nickname laughing gas. But it is really just this kind of like detached feeling from reality, kind of zooms you all the way out of everything. Honestly, it's the most I've ever been zoomed out in my experimentation with substances over the years and leaves you kind of like tingly and numb. And then I know that it can last anywhere up to a few minutes, but for me, it was always like typically under a minute after I would complete like my inhale of the gas. So it was pretty quick turnaround. And we liked it a lot in my friend group, largely because it was really accessible.
Mm.
So honestly, just didn't think that much about it. Like it was kind of everywhere. You could get it legally at my age through a variety of different places, and we just kind of never really thought about it. Like we got it at Staples sometimes, so that was kind of crazy. And then used it in kind of correlation oftentimes with like hallucinogens or other substances to kind of like boost the effects of those. So something like MDMA or ecstasy would just be made more intense for like a several moment period by partnering it with nitrous. And because it was so accessible, I actually didn't learn until my early 20s that it was so damaging and that could cause excessive, could cause like nerve damage due to excessive use, and that it could have psychiatric symptoms. So that was a revelation for sure.
Yeah, I mean, I would also say that I'll be honest, until I got into addiction medicine, I had no idea that was a thing either. Like as a doctor, I don't think I ever learned about that. So Robert, I'm wondering if we can shift to you a little bit, from your clinical perspective and expertise. Walk me through a little bit of that. Like what are some of the consequences that happen from nitrous use?
Yeah. So acutely, and I think going back to what Kai mentioned is that it's not perceived as being dangerous because acutely, not much happens unless something bad happens that
Mm,
causes asphyxiation. So nitrous is a gas, and oxygen is the gas that we need. If you get too much of any other gas, carbon dioxide, nitrous oxide, etc., then you're going to displace that oxygen, and then that's going to cause hypoxia or low oxygen related events. And so that can happen if the whatever the meatus that you're using stays attached and you pass out and then you don't get any oxygen or you're not removed from the source. But that's pretty rare and we don't see that very often. So most of the clinical concerns are actually from chronic use. And the chronic symptoms typically manifest as neurologic symptoms. And so this can be things like neuropathy or paresthesia, so that numbness and tingling or that burning pain in your extremities. Also, because it affects kind of the dorsal parts of your spinal cord, you get that loss of proprioception, which is how you feel or position yourself in space. And with that can come some ataxia or some feeling unbalanced. And a lot of people will present to the hospital or their doctors with complaints of trips or tripping, losing their balance. Um, they may come in as like a trauma in the emergency department because they're falling. And you may notice clinically, or if you're out in the community and you're watching people walk, they kind of have that foot slapping on the ground gait. And all of that is from the neurologic effects to the parts of your spinal cord. You can also get some things, some myelosuppression or some bone marrow suppression, and that may come in the form of kind of messing with your blood cell lines. Megaloblastic anemia is kind of like the buzzword for the clinical people in terms of problems with B12, which we'll get to. And then you can also have some like some long-term, more generalized psychiatric issues like depression and anxiety.
Yeah, so clearly, I mean, a lot of these almost sound like stroke symptoms, like it's so neurologically based. And then you mentioned bone marrow suppression, so decreasing our production of cells in our body. Like none of that's great. The neuro stuff is the one that I think we get the most questions about, like people with really bad neuropathy, that burning, tingling, loss of sensation in their arms and legs. And so I'm curious, like nerd alert for all the clinicians on the webinar, do we know why that happens? Like, what is the mechanism that leads to these neurologic outcomes?
Yes, thanks for asking. Completing your toxicology fellowship means you get extra nerd for basically 2 years. So, um, for a few seconds, we'll nerd out. So, nitrous oxide, what it actually does is your B12 is this big molecule, it's a big vitamin, and in the center of that is cobalt. And nitrous oxide will actually oxidize that cobalt or make it lose an electron, and that small shift is enough to make it inactive and not work. And what happens, the way that it kind of gets there is that nitrous oxide will inhibit an enzyme called methionine synthase, and the metabolic consequences of that are inhibition. You don't form methionine, you don't form tetrahydrofolate, which are required for DNA synthesis, very important, and then also myelin production. And myelin is that kind of coating around your nerves and your neurons that electrical signals use to conduct throughout your neurologic system. And so if you don't have that, then you can't have those signals, and thus the numbness, the tingling, the weakness, the problems with balance.
Okay, so if I could decompress that from the really smart toxicology perspective into my average ER doctor brain, what I'm hearing you say is when we say cobalt, right, we mean B12, that something about this destruction of that, like moving that electron, et cetera, means that even though you have the B12 in your body, it isn't working. And so therefore it like disrupts the ability of my nerves to actually communicate, to send nerve signals. And thus we see these like peripheral neuropathies, the loss of our sense of self and space. And so thinking about that, like you didn't say it was a deficiency, but if my B12 isn't working, can I just take B12? Like, is there a way to treat these symptoms? Is there a way to make them better?
That's a great question, and you actually bring up two great points. So, one, as on the clinician side of things, you may, now that you're in this webinar, you're experiencing it, you're like, oh, I'm going to look for this in my patients. What am I going to go and do? If you check a B12 level, it may actually be normal, and that's because the B12 is there, but you kind of just turn the switch off on the B12, so it doesn't work, like you mentioned. But because we inhibit that enzyme upstream, you will get some accumulation of some metabolites that are downstream. So homocysteine levels will be elevated, and then something called methylmalonic acid will be elevated as well. And so clinically, you can send those off if you're suspicious of this or worried if that's the cause of their neurologic disease.
Yeah, since those are words that I use in my everyday, just kidding. No, I don't. Probably what I'm guessing is that the best thing is to ask. Like if I'm thinking of it, if I'm hearing weird neuro symptoms, I should be adding nitrous to my differential and being willing to ask my patients about that if they have like weird paresthesias, et cetera. And that kind of brings me around to thinking about, who is at risk for this? Like what patients should I be thinking about if somebody has weird neurologic complaints? Like I'm probably not going to ask every single patient, do you use Whippets? Like I don't know if that's realistic or not. So, Kai, I know you mentioned that when we started this talk, you were like, man, flashback to my 20s or flashback to being a younger version of me. And I know when I think Whippets, like I think of youth and teens, honestly. But I'm wondering if you could speak a little bit about who are the other maybe target populations that you think of or that you know of for when we talk about who is actually frequently using nitrous that I as a clinician should be aware might make them a higher risk person.
That's a great question. And yeah, I think that youth and teens is really the focus here, especially people who are kind of ineligible, like too young to buy cannabis or alcohol. It's definitely like a lower legal age limit, and then just kind of generally available through products to people who are under 18. You don't have to show any ID at all. But I actually think like when I'm thinking back to like where did my supply come from? We had a friend who worked in restaurants, and it was really, really accessible through the restaurant industry. Lots of just laying around, so able to bring those home pretty easily, no problem. So that I would say like people who work in food service would be a target demographic just because it's the of availability. And then this is like low key a little embarrassing to admit that I know this, but if any of you out there are watching Secret Wives of Mormon or Secret Lives of Mormon Wives, worst show name ever, not a great show either, but they did have like a weird subplot line last season where, they're going as a group to get cosmetic surgery and there's laughing gas available. And the clinician, I don't know if you can really call them a clinician, but the beautician literally says, like, as she's leaving the room, like, oh, I'm going to leave this hose here for you guys, like, feel free. So she's there, one person is getting Botox, but 6 women are there doing nitrous while they're like waiting for the appointment. And I guess, because it's not like outlawed by their religion, because like Joseph Smith would be so confused by like what even is nitrous oxide. Unlike alcohol, it's not prohibited. And you see the same thing with ketamine in that group as well. So I just think that's really interesting, the like loopholes that exist.
Yeah, that's fascinating. Robert, I'm wondering from your clinical perspective if there are any other sort of atypical or surprising demographics that you would add to that list.
Yeah, absolutely. The test answer, just I'm always thinking about test questions still.
Yeah.
Healthcare workers, like has been mentioned. So anesthesiologists, emergency doctors, people who use a dentist, people who work in a dentist office. But people that might slip through the cracks are actually geriatric patients who've been using it and are addicted to it for several years, several decades. And they come in feeling off balance or having neuropathy, but we don't attribute that as something abnormal in that population. And so we don't ask about it, or we don't think about, oh, this could be caused by nitrous oxide misuse or abuse. And those are the patients that can kind of slip through the cracks for that reason.
Yeah, that's really helpful. And you're right. I mean, I see older patients with random neuro complaints all the time. And I don't think I've ever asked a single one of them about nitrous, but because it has this perceived safety, partially because of its accessibility, I mean, that's something that I really want to add to my clinical acumen. And I want to take a beat to call out a couple of the comments. If you're not watching this live, obviously you're not able to see this, but the comment section is like going off right now. And I want to call out a little bit of what's being talked about, which is that when we say accessible, this is out of control. Like you can apparently buy 340-gram canisters at Costco of nitrous. Like they sell it at Costco now, just like straight up. You can go buy it in different flavors even. And somebody posted that there's some demographic data from like shipping companies, like say Amazon as an example, that show 20-year-olds, 30-year-olds, 40-year-olds, kind of really just broad use. So I think that that's really, thank you everybody for joining with us in this conversation, that really it's like a lot of perception of safety. I mean, the Mormon community, religious communities, there's so much perception of safety and it being so different than other drugs that maybe we should be screening a lot more patients than I am. And actually, this universality of it is making me think of another question that I want to ask you both, which is like, a lot of people use nitrous in a recreational way. And I mean, I started off this webinar by saying this is a drug that I want access to in my hospital because it is one that I want to use for my patients. Like from as a doctor, it is safer than some of the other medications that we use for sedation. So it is a safe medication. It is really helpful medication. And I just want to think a little bit about like, what is the difference between when it's just something someone is doing recreationally versus when it's a problem, and when I want to make sure I'm taking an approach that is thoughtful in approaching it with my patients and thinking about when do I talk to somebody about knowing the risks versus quitting. And so maybe Kai, we could start with you. Do you have thoughts about this? Like, what is the right approach to talking to somebody who does use whippets or use nitrous in sort of discerning the difference between those two groups of people?
Well, I'm definitely like fully aware that what I can pull from is my own experience and the experience within my friend group. But it was a very recreational and social activity for us during a certain phase of our lives. And as we were kind of preparing for this webinar, I reached out to a couple people and we're kind of chatting with them about like what was the end of your experience like? Because for me, it was very defined, where I had a conversation with my doctor when I was probably like 22 or 21, where I was like, yeah, this is something, that I get with sometimes, like I'll experiment, blah, blah, blah. And my doctor shared with me that once I hit 25, I was going to see a lot more neurological fallout from doing that than I would before 25, because of how brain neuropathway regeneration works. And that made a huge impact on me. And I shared that with some people in my friend group, and some people also found that to be very impactful. Some people did not. I would say, like, now that we're in our mid 30s, most people just kind of like gently petered out over time because it was no longer a part of our social scene. Like, we could buy alcohol, we could buy marijuana, cannabis. We didn't need to disassociate so hardcore. Like, it just wasn't a part of the experience that we wanted to
Right.
have anymore. But yeah, I did not use anymore after I was 25 because of that conversation. And I will say that, like, I do have a couple friends who have continued, up into our mid 30s, and you can tell at this point,
Mm.
like, when we're having a conversation, I mean, it's obviously not that alone. There are other factors, but it's a difference in cognition that is perceptible after 10.
Yeah. Yeah, definitely. Robert, I'm wondering, as a clinician, if there are other thoughts that you would layer onto this, things that would be more obvious. And maybe some of it is obvious, but I just want to hear from you. Like, what are some of the more, gosh, I we really need to sit down and talk about this, feelings that you have with a patient.
Yeah, I agree with Kai that harm reduction is the way to go. And I think everybody that's using this needs education on it, right? So education on acute and chronic effects, and so that they can make, good decisions for themselves. And then people who need maybe more immediate interventions are definitely the people who have used to the point where they are having some of these chronic effects. So if they're having neurologic symptoms, especially, then they would, meet the criteria that they may need more intensive intervention. Any signs of addiction, if it's negatively affecting their life because of use, like Kai had mentioned with some of her experiences, and if you can't perform your ADLs either because of the neurologic symptoms or because of the social components of your use. Then those are all people who I would say need a more immediate intervention and more intensive, um, meeting with substance use counselors, therapy, and other things we'll talk about with treatment.
Yeah. And then I don't remember which one of you mentioned it earlier, but this idea of like withdrawal. I'm wondering, Robert, while we've got you unmuted, what does nitrous withdrawal look like? What am I looking for? What is it? What is the pattern? What is that? What does it look like?
Yeah, it's not well defined, and there's like a whole list if you look this up and you look at the case reports of symptoms that people describe, and they're very non-specific. Some people report feeling shaky, although clinically they don't have necessarily the tremors that you would see with like alcohol or benzodiazepine withdrawal. People report just not feeling well, whether that's malaise, fatigue, having a headache, but they don't have a lot of the overt clinical signs that you're astute to with opioid withdrawal. You're not going to see like fluid coming out of places or goosebumps or piloerection. It's just generally the people who've been using it for decades, typically the geriatric patients. They have a lot of internal anxiety, and then subjective symptoms that we can't necessarily pick up on right away.
Sure. And so we talked about B12 being a way that we could treat some of those more neurologic symptoms. are there any treatments that are approved or recommended for patients who are experiencing that withdrawal?
For withdrawal, it's really going to be symptomatic control. So if they're having a lot of anxiety, the one physiologic thing that if people are going to develop is probably going to be some of that tachycardia, um, and that and the anxiety and the agitation that can be treated with benzodiazepines, toxicologist's favorite drug. Um, there's not a specific treatment or antidote where you're going to reverse any of their physiology necessarily.
All right, so no FDA approved medicine,
Right.
but benzodiazepines can be helpful. And because I know that you, as an addiction medicine and toxicology person, like would kind of also know what's on the front line of things, I'm curious, are there any medicines that might be coming down the pipeline in the future that might be helpful? I mean, maybe I'm not going to implement those now, but I'm curious, like, is this an area that's being developed or researched any further?
Yeah. So, in terms of the neurologic symptoms, we primarily treat with B12. We replace their B12 with a working B12. The most important thing is to stop. If they don't stop, giving them B12 is not going to help. It's worthy to note that in these like case reports in these studies, before they started using B12, even when people just stopped, they did get better. Not There are case reports of people not getting better, so that it can be irreversible in people who use for a long time. But it seems anecdotally and from a lot of the case reports, and there could be reporting bias with this, that people get better faster with B12 supplementation. In terms of other treatments, and so not necessarily for the neurologic symptoms, but for some of the cravings and some of the kind of post-acute withdrawal that we see with a lot of other substance uses, there are people who are using gabapentin with some success, as well as case reports of using naltrexone for specifically for cravings, and may help that feeling, that endogenous opioid release that you get. It may reduce some of those cravings and feeling like you're missing it or things like that.
Yeah. Okay. So maybe someday naltrexone, gabapentin, thinking about the cravings, thinking about Wellbutrin, like treating again, more just the symptoms and that kind of thing. So when I asked my earlier question, and as you were both answering it about like, how do you, know when to talk to patients about it, it kind of triggered this other thought for me, which is that I think a lot about nitrous the way I think about cannabis, which is that can be a delicate conversation with my patients because I do have a lot of patients who don't think cannabis is dangerous, right? And like, unless they're experiencing hyperemesis cannabis syndrome or like actively having, medical issues associated with their cannabis use, it's like a conversation I'm not usually going to succeed in. And so I often will choose to think more harm reductionist, like, well, please don't get high and drive, right? Or don't get high alone, like things like that. Is it affecting your life? Those sort of same addiction style screening questions. But it's becoming obvious to me, first of all, watching the chat talking about how really like nitrous has changed over time, is so accessible, is like a different product even than it was when maybe I was a younger person, and I knew people who were using nitrous. Like, I want to be able to have this conversation, but I want to be able to do it in a way that isn't pejorative and like I'm lecturing youth about like don't go be using whippets, you youngins. Like that's not going to be received well. And I'm thinking about these cannabis conversations as a way that I'm just wondering. Kai, you mentioned that your doctor had a conversation with you and that you did end up quitting. I'm curious if you wouldn't mind elaborating on that conversation and what maybe are some takeaways that you would offer anybody on here thinking about the right way to approach that conversation with the patient?
So it's been really interesting to hear Robert speak about this, especially from like a clinical perspective, because I really think thinking back to what my doctor told me about, oh, your nerves will be damaged and then they won't be able to talk to each other. You won't be able to form new neural pathways. That's such a simplified version of what Robert was saying here in this space. But I totally see in retrospect why my clinician chose to phrase it to me that way, because it was like a huge oversimplification, but it got me the information that I needed to have, which is that I would have that I was risking very severe neurological damage, that it was a near certainty if I continued this in a longer term context. So that was really, really helpful. It was the right amount of information given at the right level at the right moment. So that was really impactful for me and ultimately kind of led to me making the decision of, okay, this is where my cutoff point is for this, because past that point, I'm taking risks that I don't feel comfortable taking. So it let me decide how much risk I felt comfortable taking in that moment and set those boundaries. So it was a very empowering conversation. Because I mean, I think if she had gone in and said, like, you should never do this again, it's horrible for you, I would have been like, screw you, I'm getting a new doctor.
Right.
So it definitely like furthered the conversation.
Yeah. Robert, I'm wondering from your being on the opposite seat in that same conversation and probably doing this more often than the average, say, emergency doc, because you did this fellowship, what tips do you have from your own experience? Like, what would you offer us as a way to approach this subject?
Yeah, I think Kai actually hit on some really good points. And kind of a side branch of what she was saying is really to get to the why, which is a foundation of like substance use treatment in general. You know, are you doing this? Are you self-treating for something? Is it the euphoria that you're after? Is it just a social thing? Is it just because your friends are doing it and this is what you guys do after school? And then trying to really kind of understand them. I think also having the conversation with you mentioned cannabis and nitrous, and cannabis can be really difficult because of the marketing with cannabis and how, you know, everyone has this well, it's a fact and the perception that it's a plant, it's natural, it comes from the ground, and because it comes from the earth that it can't be bad for you, even though I could think of literally 1,000 poisons that come from the earth that are really bad for you and will kill you. um, Nitrous, they don't have that perception, even though, because it's not natural, it's a chemical. Even though it's a gas, they perceive it as a chemical.
Mm.
And so it seems to be more well received on that end. There's not a lot of kind of confrontation like you get with talking to someone about their cannabis use and cutting down. So that's a good thing from our perspective. I think one of the tools that I offer or that I try to um, give to people is like specific language that I try to use. And so what I tell them that is that my concern is that they're not going to be able to use your brain and your body the way that you want to, especially for young people. You know, if they want to continue to play sports, if they want to ride bikes, if they want to be active, even if they just want to be able to get up and down the stairs to their game room and their bedroom. If you use this for long periods of time, that could not be reality for you.
I am 100% direct stealing and ripping off that language. There's a couple of comments in the chat too that we all just are obsessed with that wording. I'm concerned that you will not be able to use your brain and your body the way that you want to. That's beautiful and perfect. And with that, we probably could do an entire webinar or daytime like seminar in general about how to talk to a patient about substance use in a way that is harm reductionist and open and gives them agency. But I think that your pearls are so spot on, and I appreciate both of your time. You have no idea how excited I was to learn from you today, and hopefully everybody in attendance agrees. But before we go, let's just do a quick recap because we got nerdy, we got practical, we got first person narrative from, we got all this information. Let's just put it all together. So first, nitrous oxide, important medication and definitely really safe way for us to sedate patients in the hospital. I encourage us to have it in the hospital. Really important thing that we want to have available in our our toolkit, but it is very, very commonly among all kinds of patients recreationally used, in part because it is so accessible. And that also then gives it this perception of safety that a lot of people, it's so short lived. You're not like driving a car, it's not, it doesn't seem addictive, at least at face value. And so when you inhale nitrous, it can lead to that euphoric, really giddy feeling, hence the nickname laughing gas. But there are these long-term potential consequences, mainly really bad neurologic symptoms, those really bad paresthesias, neuropathy, like nerve pain or loss of sensation in your arms and legs, loss of yourself in space, that proprioception, ataxia, inability to walk and balance well, and having to kind of like slap your feet because you can't really feel where they are, and a lot of tripping and risk of falls. So all these things are because of a functional B12 deficiency. So the level, if you measure it, would be normal, but they look like they have B12 deficiency clinically. And the way that we can help that first line is by giving that vitamin B12. So easy, so cheap. What a great solution. They may not get a full recovery, but if they stop using nitrous and they get on that B12, that can expedite their journey into recovery away from those symptoms, which is amazing. patients can and do go through nitrous withdrawal. It won't be as objective to see the way that alcohol withdrawal has like tongue fasciculations and tremulousness and seizures, and it won't look like opioid withdrawal where everything is running. They're like sweaty with the runny nose and the diarrhea and the vomiting, but you will see some of that internal anxiety, maybe some fast heart rate tachycardia. Patients will feel the withdrawal more than we can visibly see it with our eyes. And so if someone has withdrawal, first of all, if they have those neuro symptoms, you can give B12. If they don't, it's not going to help them. Otherwise, you might use benzodiazepines. And if you're somebody with a lot more experience interested in being cutting edge, you could consider things like naltrexone and gabapentin, but those are not yet FDA approved or ready for prime time. And I know that we're all looking forward to hopefully some of those studies coming out in the future to give us more options. Remember to think about high-risk patients, but I think what we've distilled it down to is like, hello, everyone is a high-risk patient. And so just think about it, especially in patients with weird neuro complaints that don't make sense to you, or people who are really anxious. Like, is this on your differential? And if it's not, it certainly should be. And when we think about talking to our patients, focusing on a harm reduction approach, educate, empower, and then let your patients make their own decisions, which is what we always say with all substance use. Radical acceptance, help people live well, help them understand the consequences of their choices, but empower them to do whatever they're going to do safely. So the day that they are ready to quit or they are ready for help, they trust us, they build a relationship with us, and we've helped to just dismantle these years of stigma and separation that the House of Medicine has built with our local communities. So let's keep dismantling all of that together and instead building safe havens in our emergency departments. And I want to give one more gigantic thank you to both of you, Robert. Hopefully I would jokingly say like you were a first-time visitor, long-time listener, but maybe you weren't. Either way, we love having you. And Kai, it is always just a privilege that you say yes to me when I invite you to these things. And we will send an email at the end, but if you have any questions or anything that you want to know, please reach out to us at info@bridge2treatment.org. And if you are looking for any other education, we have entire CME libraries available on our website. And in the meantime, thank you all so much for your time today and for everything that you do to help us save lives. Have a great week.